Okay, erythrocyte production, that process is called erythropoiesis. Okay, don't confuse erythropoiesis with erythropoietin. They sound similar. Erythropoietin is the hormone. For short, we say EPO. And the kidneys are what make and release the erythropoietin. Okay, the stimulus is low oxygen. Okay, so if you have low oxygen, the kidneys are going to release EPO or erythropoietin, and that hormone goes to the bone marrow. To tell the bone marrow to make and release red blood cells. All right, so it will actually communicate to the stem cells, the hemopoietic stem cells, and this is the embryologic process with the colonies and the precursor cells until eventually you make the final product, an erythrocyte. And so what that will do is increasing red blood cells will therefore increase your oxygen carrying capacity. So people that move to Colorado from sea level, let's say from Florida, obviously Florida is sea level, and they move here to 5,300 feet or higher, depending on where you live. And the oxygen is going to be less because we are higher above sea level, and those that move here will struggle for the first couple weeks or so. So if they go up and down flights of steps or try to run and whatever, they're going to feel it, right? They're going to tell that they're oxygen deficient, but no problem. The body will compensate, and erythropoietin will be released, go to the bone marrow, and you're going to spit out a bunch of red blood cells to adapt. Okay, this is also where altitude training comes in. There's a lot of athletes that will come here on purpose to train at altitude, and then they'll go back to wherever they came from, like California, and do their event, the marathon, the triathlon, and all that. Okay, here is a diagram of what we just talked about with hypoxemia. So that is a fancy way of saying low oxygen, okay, hypoxemia. And the kidneys will get involved, release their EPO, go to the bone marrow, and it will spit out a bunch of red blood cells, and that will increase oxygen transport. Iron metabolism. So iron is a very important nutritional requirement, and men end up losing about 0.9 milligrams of iron per day, and women of reproductive age lose around 1.7 milligrams a day. Part of that factor is monthly cycles. When we eat, first of all, there's foods these days do not have a lot of iron in them because soil is depleted of iron. A lot of food is processed and ultra processed, which means a lot of things and nutrients and stuff were taken out of it. So, because we only absorb a fraction of the iron in our diet, we have to. It's a good idea to supplement with iron. Okay, so we need about 5 to 20 milligrams a day to replace the losses. And during pregnancy, about 20 to 48 milligrams a day, especially in the last 3 months, as that baby is growing. And at that point, I mean, it is rapid, crazy growth. up until month 9. Okay, when we eat iron, it starts out as Fe3 and then gets converted into Fe2. And that is done by the stomach acid and a protein called gastroferritin, which is produced by the stomach, will bind to the Fe2, which is the form of iron that the small intestine can absorb. And it will transport it. Okay, notice the word transport. The iron to the small intestine. Here it's absorbed in the blood and binds to a protein called transferrin. Okay, so like transportation. So this is a movement of the iron. Okay, the transferrin will now take the iron to the body, so bone marrow, liver, and other tissue, so that in the bone marrow, the iron is used for hemoglobin synthesis. In muscle, it's used to make myoglobin. And virtually all cells in the body need iron, especially for the electron transport molecules. And that feeds the mitochondria, which eventually helps give you ATP. Iron is also stored in the liver, and the protein that helps the storage of iron is called ferritin. In fact, when you do a blood lab on someone for iron, you want to do the lab on iron itself, but you also want transferrin. You want the ferritin, and you also want what's called total iron binding capacity. Okay, so in my practice, I make sure that we get all 4 in. You don't want just iron. You want to make sure that you get all 4 of those to make an accurate diagnosis and therefore an accurate protocol, because it is possible to overconsume iron and then create a problem. Okay, so make sure all 4 of those labs are done. All right, here's a animation of what we just talked about. So this is the drawing version of what was written with the iron being converted into Fe2, and gastroferritin is released to help transport the iron into the small intestine for absorption. And of course, once it gets into the small intestine, eventually that means it's going to get into the bloodstream and travel throughout the body. Okay, the fate of a red blood cell is they live about 120 days. And when they are dying, they will go to the spleen, known as the erythrocyte graveyard. Okay, the spleen will essentially break down and send some components from the red blood cells back to the liver. So some of it can be recycled, like iron, for example. Some of the byproducts you're going to get rid of, like bilirubin. Okay, the spleen is actually considered in the lymphatic family. So your lymph nodes, your tonsils, the thymus, and the spleen. So those are all in the lymphatic family. And one of its job is to phagocytize, and that it means it has cells that are able to break things down.